Hi, I'm Dr. Aria Fallah. I'm a pediatric neurosurgeon here at UCLA Mattel Children's Hospital, and I specialize in epilepsy surgery in children. And today I'll be talking to you about epilepsy surgery for intractable infantile spasms. I have no relevant disclosures to this talk. I actually want to start off by playing a video that really captures what infantile spasms really are. So what are infantile spasms? They're actually a very severe form of epilepsy, affecting about 2,000 children in the United States each year. They're very subtle and can be easily missed, especially to the untrained eye and even to some general pediatricians who may not be familiar with this condition. It is the most common epilepsy syndrome within the first year of life, usually happens by about 4 to 6 months of age, and it actually resolves by about 2 years of age. But the concern is if they take their toll and they are not stopped with medications or through surgery, that they can have long-lasting effects on the brain. Delay to diagnosis is quite common. As you saw, the symptoms and the way it presents, it looks like it's benign, but it's far from it. And it's actually quite challenging to treat. The big concern with infantile spasms is that it can, if untreated, can lead to a condition called West syndrome. West syndrome is the triad of having infantile spasms, a specific EEG pattern called hypsarrhythmia, and as well as developmental delay. If untreated, the prognosis can be poor. There is a certain proportion of patients that may do well and may have a normal IQ, but for the vast majority, especially untreated, they can have a higher risk of developing autism spectrum disorder, development of a very severe epilepsy condition in the future called Lennox-Gastaut syndrome, with multiple seizures that cannot be controlled easily with medications or surgery, as well as low IQ and even the risk of premature death. The shorter the duration between the onset and successful treatment and resolution of the spasms, the better the cognitive outcomes for that specific child. So early recognition is key, and early treatment is absolutely essential. What causes infantile spasms? So it turns out that almost any condition in the brain at a very young age can give rise to infantile spasms. So any sort of brain injury, hypoxic ischemic encephalopathies that can happen around the time of birth, any brain malformations, and those are usually the ones that require brain surgery to treat, a brain infection, neurocutaneous disorders such as tuberous sclerosis complex, which are disorders that manifest in the brain as well as the skin, any stroke or bleeding inside the brain, as well as genetic disorders, metabolic disorders, as well as brain tumors. So the cause can be quite varied. What are the first-line treatments? I'm going to briefly mention them. These are usually treatments that are initiated by a pediatric epileptologist who specializes in this condition. The most common therapies are prednisolone and ACTH. These are hormone steroid-based treatments, and they work quite well. In a specific condition, specifically for tuberous sclerosis complex, the first-line medication is vigabatrin. Each of these medications have their own specific side effects, so they are not entirely benign. And the idea is that you have to try to stop the spasms as soon as possible. So if one medication doesn't work within usually a period of 2 weeks, you want to try a different medication and try to get those spasms under control as soon as possible. If those don't work, there are second-line treatment options, such as the ketogenic diet, as well as other anti-seizure drugs that can be tried, as well as surgery. So the focus of today's talk is about the surgical management of intractable infantile spasms. So that means spasms that are not responsive to first-line treatment. So when should you consider surgery for epileptic spasms? When you have failure of the first-line medications, when you have or intolerance of the first-line medications, and specifically in situations where you have an underlying recognizable surgical syndrome. There are certain conditions, just listed a few here: megalencephaly, focal cortical dysplasia, tuberous sclerosis complex. These are surgical syndromes, meaning that the likelihood of sustained treatment and successful treatment with medications alone is highly unlikely. So you do want to consider surgery, and you want to consider it as soon as possible. Clinical findings can be very important, so a good history and physical exam is very important. Particularly in terms of surgery, you want to focus on whether the child has any hemiparesis, which means any weakness on one side of the body compared to another. That can be an important clue as to where the abnormality in the brain is that is giving rise to the infantile spasms. The other thing you want to look out for is early handedness. So any infant below the age of 1 who develops a hand preference is considered to have an abnormal early hand preference, and that can be a sign of a brain abnormality. It is rare for any infant to have a hand preference before 1 year of age. You want to do an EEG as soon as possible. This particular EEG pattern is that of hypsarrhythmia, which shows this large amplitude, chaotic brainwaves. And this is not what a normal brain EEG should look like. And this is quite concerning. Again, with this finding, as well as infantile spasms, this child, if left untreated, has a very high likelihood of developing West syndrome. The other thing that the EEG may find is that there may be an asymmetry between the left and the right side of the brain in terms of the brain waves. And if you do have an asymmetry of either the spasms or just the background, that may be a helpful clue as to where the seizures may be coming from, or at least being able to lateralize whether it's the left or the right side of the brain. A high-quality MRI is also very useful. This is a 3 Tesla MRI, which is a very strong magnet that allows us to get fine detail of the brain. Sometimes the abnormality can be quite obvious. Other times it can be quite subtle. This is an example of a child that has left-sided focal cortical dysplasia. Keep in mind that as neurosurgeons, we look at thousands and thousands of these scans, but unless you know exactly what you're looking for, it's very easy to miss the abnormality, which in this case is some abnormal myelination of the brain. So if you can see, this black area comes all the way back on this side of the brain, but it does not on the other side. And that is a sign of a left-sided focal cortical dysplasia. Again, can be extremely subtle, and this is the type of thing that you want to get a second or a third opinion by a very experienced neuroradiologist who has training in looking for these very subtle abnormalities. Because if we find these subtle abnormalities, there is a possibility that we can cure the child long-term of spasms and seizures with an operation. We quite often also use FDG PET. which is a sign of metabolism of the brain, to look to see if there's any area that has abnormal metabolism. What you see on the right-hand side is the MRI. What you see in the middle is the PET scan done with a CT scan. And on the right side, you see the fusion of the MRI and the PET scan into this color-coded image. And what you can see here is that there is an asymmetry of the brain between the right and the left side. In this case, you can see a lot more of the green colors on this side, but more of the red colors on the other. And in this particular situation, the left side of the brain is where the seizures or the spasms are originating from. Again, this is a child that we can cure very easily through a surgical operation. So this is the pre-surgical evaluation for infantile spasms that we perform at UCLA. Again, starts with a history and physical examination, followed by a video EEG, a 3-Tesla MRI, and a FDG PET scan. And after this, we have a multidisciplinary patient care conference where we have a group of 20 or more physicians who discuss all parts of the evaluation and investigation and decide upon whether that child is a good candidate for a surgical operation to treat the spasms. Now, the types of operations that we do are varied. I will talk to you about a few of them. The surgery can range from as small as a lesionectomy to as large as a hemispherectomy. So in the case of a very focal or very small abnormality in the brain that's causing the spasms, such as a brain tumor or a condition called tuberous sclerosis, here I showed you a picture of this part of the brain that looks abnormal. It's an expanded gyrus and is actually, this is a child that has tuberous sclerosis complex. And the curative treatment is to go in surgically and remove this part of the brain that's causing the infantile spasms. Now, quite often when the infants are very young, the abnormality in the brain that leads to infantile spasms can cover a very large part of the brain, and sometimes as much as half an entire brain. So these are situations that we may perform a hemispherectomy. A hemispherectomy is an operation that's been around actually for a very long time, and it's very safe, but it's a radical operation where we would remove either the entire half of the brain or remove a portion of a half of the brain and disconnect the rest of it in order to stop the seizures. These are extremely effective operations in giving us long-term seizure freedom, and in certain children, this is the best operation to do at a young age, where we can also take advantage of neuroplasticity, meaning that the brain can rewire itself on the other side to carry out function on both sides of the brain. So this is a range of the types of surgery we do to remove a certain part of the brain, as small as a lesionectomy to as large as a hemispherectomy. Now, in certain situations, we cannot figure out exactly where the seizures are coming from, or the spasms. And the big challenge to the spasms is that they travel through the brain very quickly. So even though they may be starting from one particular location, when we're capturing it on our EEG, it can look like it's coming from the entire brain. And when that happens, it's very difficult for the team to confidently say that removing a certain part of the brain can be effective. So the other operation that's most commonly done for intractable infantile spasms is a corpus callosotomy. I'll show you what the corpus callosum is in a second, but this is really the major connection between the left and the right side of the brain. Think of it as a major highway that connects the left and right side of the brain. I'll show you scenario 1 here. This is a child that may not need a corpus callosotomy. Their seizures are starting from one part of the brain and affecting the body, and we can see a clear abnormality on the MRI, clear abnormality on the EEG. Usually there's an abnormality in the neurological exam of the child where one side of the body is weaker than the other. And in those situations, we can move straight from an evaluation to a resective operation where we remove a certain part of the brain to make the child seizure-free. In these other scenarios, scenario 2, 3, and 4, quite often we need to do a corpus callosotomy first. So scenario 2 is that the seizures are starting from one part of the brain. It seems like it's obvious, but because that a lot of that seizure is very quickly crossing the corpus callosum to the normal side of the brain, it is difficult for us to be sure. So in those situations, we may perform a corpus callosotomy, and once that connection between the left and right side is gone, it is very clear that the seizures are coming from one particular part of the brain. So those are patients that you can do a curative operation after the corpus callosotomy to stop their seizures. Scenario 3 and 4, these are patients that may have 1 or 2 foci in the brain. And in scenario 3, the connection between one side of the brain to another is weak. So if you do a corpus callosotomy, you're not going to be able to slow down the spasms or seizures. And these are patients that may have no or very mild benefit to doing this procedure. On the other hand, in the last scenario, these are patients where the corpus callosum is integrally involved and very important in the generation of the spasms. And for those patients, if you were to do a corpus callosotomy, you're either going to see resolution of the spasms or a major decrease in the amount of them. So these are 4 possible scenarios. The way I like to summarize is that about a quarter of the time with a corpus callosotomy, you'll be able to stop the the spasms completely. And with another 25% chance that you may not stop the spasms completely, but you may be able to better localize the seizures and follow it up with a more curative operation. Those numbers may not seem very high, but in the children that have failed treatment to first-line medication, those numbers are actually pretty good and quite favorable to alternative treatment options. So I wanted to talk to you a little bit about what a corpus callosotomy is. So this is the corpus callosum. You can see on a sideways view of the brain, connects the left and right side of the brain. And the traditional way to do this operation is through open brain surgery, where we make an incision on the top of the head, remove a part of the bone, and then we sneak in between the 2 halves of the brain and disconnect this structure here, this white structure here. It's the corpus callosum, and we can disconnect it all the way from the front to the back. This really has no consequence in children that are very young or children that are already quite delayed as a result of their spasms. There is no function that gets lost by doing this type of operation. And it, like I said before, can be very helpful in either stopping the spasms completely or at least helping us better lateralize on EEG where the spasms may be coming from. Now, if you read about corpus callosotomies, you may come across some data that sometimes a part of the corpus callosum is disconnected and part of it is left intact. In our experience, partial corpus callosotomies don't really work very well. So if you want to do this for infantile spasms, and usually in children that are very, very young, you definitely want to do the complete corpus callosotomy. Otherwise, the spasms still spread so quickly in the brain that if you just partially disconnected, it may not make any difference on an EEG. The other option that is a newer approach to do a corpus callosotomy is to do a minimally invasive approach where we make a small skin incision. Here you can see 3 small skin incisions, and then we pass down laser fibers through the brain into the corpus callosum, and then we use heat energy under guidance from the MRI to disconnect the fibers of the corpus callosum that are connecting the left and right side of the brain. The nice thing about this operation is that it avoids a skin incision, avoids a craniotomy where we have to lift a portion of the bone up. But the downside is this is not easy to do in an infant because their skull isn't rigid enough to accommodate these laser fibers. And the other concern is that it's very difficult to know that you've done a complete corpus callosotomy until you get imaging 3 months later, which may not seem like a big deal, but for an infant that's only a few months old, you want to know right away if you're able to stop the seizures, and you'll want to know right away if your corpus callosotomy is complete. So this could be an option in select patients, but for the vast majority, the open surgical option is quite safe and probably the best approach. Now, if those don't work, you have second-line surgical treatment options. None of these have great data for infantile spasms, but they are used if all else fails. On the left side, what you have is a vagus nerve stimulator. Again, there's very modest benefit reported in very few studies, but what this is, it's an implantable device that goes in the chest, and the electrodes sit up in the neck, and it uses this nerve as a conduit to send electricity up towards the brain to try to make it more difficult for that patient to have seizures or spasms. On the right side, there's even less data on both deep brain stimulation or responsive neurostimulation, where electrodes are placed directly inside the brain to target seizures. Both of these devices are approved in patients 18 years of age and older, so using them in infants or children is considered using them off-label, but they're also newer devices for epilepsy. The main difference between the RNS and the two other systems is that the RNS is a responsive neurostimulator, so it needs an electricity signal to act on. So usually we need to capture seizure activity to train the device to send an impulse to try to stop that from occurring. The big challenge with spasms, obviously, is that they happen so quickly in the brain that it's quite difficult to treat that way as well. But these would all be on the table as a second-line surgical option if all else fails and there's no real other option. That is the end of my talk. Thank you for listening. If anyone has any questions, please send them in. And we're always here, UCLA, happy to help you if you have a question about a patient of yours or yourself or your family member about a child that has infantile spasms. Thank you very much.